Management of endometrial hyperplasia, Royal College Green Top Guideline number 67. This is part 1 of this lecture. In the whole lecture, our learning objectives will include introduction, risk factors, classification, diagnosis and surveillance, management of endometrial hyperplasia without atypia, management of atypical hyperplasia, special considerations. Endometrial hyperplasia is defined as irregular proliferation of the endometrial glands with an increase in the gland to stroma ratio when compared with proliferative endometrium. Endometrial cancer is the most common gynecologic malignancy in the Western world, and endometrial hyperplasia is its precursor. In the UK, more than 8,000 new cases of endometrial cancer were registered in 2012. The incidence of endometrial hyperplasia is estimated to be at least 3 times higher than endometrial cancer. The most common presentation of endometrial hyperplasia is abnormal uterine bleeding. This includes heavy menstrual bleeding, intermenstrual bleeding, irregular bleeding, unscheduled bleeding on hormone replacement therapy, and postmenopausal bleeding. Risk factors of endometrial hyperplasia. Endometrial hyperplasia develops when estrogen unopposed by progesterone stimulates endometrial glands, binding to estrogen receptors in the nuclei of endometrial cells. Risk factors include increased body mass index with excessive peripheral conversion of androgens in adipose tissue to estrogen, anovulation associated with the perimenopause or polycystic ovary syndrome, estrogen secreting ovarian tumors as granulosa cell tumors, drug-induced endometrial stimulation as systemic estrogen replacement therapy or long-term tamoxifen. Endometrial hyperplasia classification. The first classification system was introduced by the World Health Organization in 1994, and it divided endometrial hyperplasia into 4 categories. First, simple hyperplasia. Second, complex hyperplasia. The third is simple hyperplasia with atypia. The fourth is complex hyperplasia with atypia. The second classification system was introduced by the Endometrial Collaborative Group, and it was called the EIN classification in 2000. It divided endometrial hyperplasia into 2 categories. One is endometrial hyperplasia. The second is endometrial intraepithelial neoplasia, EIN. The final classification is the revised WHO classification that was introduced in 2014, and it divided endometrial hyperplasia into 2 categories. The first is non-atypical endometrial hyperplasia or benign hyperplasia, and the second is atypical endometrial hyperplasia or endometrial intraepithelial neoplasia, EIN, / well-differentiated carcinoma. The current working classification is the revised WHO classification of 2014. Diagnosis and surveillance of endometrial hyperplasia. Diagnosis of endometrial hyperplasia requires histological examination of the endometrial tissue. Endometrial surveillance should include endometrial sampling by outpatient endometrial biopsy. Diagnostic hysteroscopy should be considered to facilitate or obtain an endometrial sample. especially where outpatient sampling fails or is in non-diagnostic. Transvaginal ultrasound may have a role in diagnosing endometrial hyperplasia in pre- and postmenopausal women. It detects an irregularity of the endometrial profile or an abnormal double-layer endometrial thickness measurement. Women with polycystic ovary syndrome and absent withdrawal bleeds or abnormal uterine bleeding, a transvaginal ultrasound should be considered as advised by the Royal College. Direct visualization and biopsy of the uterine cavity using hysteroscopy should be undertaken where endometrial hyperplasia has been diagnosed within a polyp or other discrete focal lesion. These investigations are not recommended and should not be routinely used. They include CT, MRI, and biomarkers. This concludes the first part of our lecture, and thanks for your attention.